NSIP does not have honeycomb. IPF or UIP has honeycomb. This is the main difference in CT. So otherwise, the progression or the behavior of NSIP is similar to IPF. So that's why both are clubbed together in single category. I hope you remember this slide. They are clubbed in chronic fibrosing ILDs. So this is the classification: chronic fibrosing, idiopathic pulmonary fibrosis, and idiopathic NSIP. NSIP behaves similarly to IPF, but it is slow. It has slower progression and it has slightly better prognosis. So if the patient does not have honeycomb, they have slightly better prognosis. So NSIP clinical picture is same as IPF, although patients tend to be women, younger in age, who never smoked, often associated with connective tissue diseases, HP, HIV. Lung biopsy may be required for diagnosis, and prognosis is better than IPF. Respiratory bronchiolitis, usually it is seen in smokers. So these are smoking related ILDs, RBILDs, and DIP. Smoking cessation leads to improvement, and natural history is unclear. Some patients progress in spite of smoking cessation, and some majority of them do not progress. Organizing pneumonia is a specific clinical entity where there is a specific organizing pneumonia pattern, which is usually associated with some autoimmune diseases also, or it may be idiopathic also, and they usually respond to corticosteroids. So they have excellent response to corticosteroids. Acute interstitial pneumonia is also known as diffuse alveolar damage. It is usually similar to ARDS, acute respiratory distress syndrome. The only difference is in ARDS, there is a known clinical insult. In acute interstitial pneumonia, there is an unknown cause, but the clinical picture and presentation is similar, and its prognosis remains poor. Mortality is more than 50%, and the course is rapid with widespread bilateral pneumonic consolidation and diffuse alveolar damage on biopsy. Dysphomic interstitial pneumonia is again a smoking related disease, which is a continuum of in initial stages patient have RBILD, in later stages he may be having DIP. So it is histological hallmark is excess accumulation of macrophages in intraalveolar spaces with minimal interstitial fibrosis, usually occurs in 4th or 5th decade. Better prognosis in response to smoking cessation. So both these smoking related ILDs have a good response to smoking cessation, and minority of the patients still progress in spite of smoking cessation. LIP is a rare ILD, so usually it is associated with HIV or lymphoma. It is more common in women. It has a slower onset over years, and connective tissue disease or HIV or lymphomas may be associated with it. Steroids are again helpful in these diseases. So steroids are helpful in majority of interstitial lung diseases except UIP. So in UIP, you do not give steroids. Steroids are not recommended in UIP or IPF, but in other diseases, most of them, the steroids are helpful. Many drugs also cause interstitial lung diseases. Common one are mainly anti-cancer drugs like methotrexate, cyclophosphamide, amiodarone can sometimes cause, nitrofurantoin can sometimes cause. So these are the common diseases. When there is a significant exposure and there is a pattern of ILD, we have to rule out the drug history also before labeling the patient as ILD. So there may be a drug-induced ILD also. So thank you.